neuroradiologist. Okay, I present endoluminal reconstruction of the dissecting aneurysms localized in vertebro-basilar territory. This type of aneurysms have two important points. One is hemodynamic impact, and second is the recanalization, because it's dissecting aneurysms. This origin of dissecting aneurysms is possible secondary to trauma, also sometimes it's spontaneous. 1 to 10% have a subarachnoid hemorrhagic. The prognostic is very poor because the patient rebleeding, 70% rebleeding, and 50% in the first week after the first bleeding. This is a very problematic situation to the patient because I have a high risk of bleeding and death. I like to present, this is the precoce bleeding in 1 week and 700% in 24 hours. Also is, I need, in my opinion, personal experience, I need to treat it in emergency situation, no delay, because it's very poor, the wall of the aneurysm. This is the situation. This is the dissection of the intima, and then the blood glowing not only in this part, also in the medium. And this is the high risk to rupture. This is the problem. I present some examples. This is a junction vertebro-basilar aneurysm. This is probably post-traumatic. You are the pica origin in the sac, if you want. The point of dissection is this point to this. This is the angio in lateral view. The pica, oblique, the ica. Probably the dissection finished here in this point, no here, here. And the origin is about this. I decided to treat it with some Leo stent, is French bad company. This is the CT reconstruction. This is axial view. This is the Leo stent, and this is the aneurysm. The lateral reconstruction. This is the second Leo. This is the reason you are two markers. Axial view. And some week later, you are reduction of the size of the aneurysm. Control angio, AP view, before, after 1 week. And the patient is protected from this situation. Okay, another example. This is left vertebral basilar aneurysm, dissecting aneurysm. Also have a small dissection aneurysm in distal part of right vertebral. And this is the right vertebral, this is the pica, and this is the second aneurysm. Lateral view to the left side. The dissection is coming to this point, to this point. I decided to treat it with Leostem also. And when I finish the treatment, I check the right side aneurysm and look, have a decrease the size of the aneurysm. Probably is the phenomenon of theory of Bernoulli effect. You have more high flow in this side and you are less flow in this side. Oh, I don't know why, but change the flow in the region. 1 month later, the aneurysm is totally reconstruction of the vessel. This is the 2 Leo stem also. This is before, after 1 week, after 1 month, totally disappear the right side dissecting aneurysm. Probably to change the flow in the region. Also, some cases more difficult because when you put the stent is possible move in the vertebral or basilar artery. This is the reason because I used one time assisted balloon remodeling technique. This is a 30-year-old male. This is the MRI CT scanner in acute phase. And in the angio, you are this dissecting aneurysm in the right pica. 3D reconstruction, you are, the dissecting point is to this part, to this part. This is lateral view. It's a similar to blister aneurysm. And it's spontaneous, it's not traumatic, this case. When I decided to put the microcatheter with balloon here, the problem when you remove the lead wire support the catheter, is possible you going out with the stent here. I decide to use a balloon to protect when I detach the stent. This is the Vertebro-Basilar pica aneurysm. This is the catheter in distal part of the pica with the guide wire. This is the balloon expandable stent, cardiac stent. Why I decide to use this and not auto-expandable stent? I decide to use the balloon expandable stent because it's more precise to place the stent just this part to this part. I open the stent without inflate the balloon, but when I move the guide wire, some in the cerebral and the placement of the stent, I decide to inflate the balloon and remove catheter and the guide wire. And this is the final control. You are showing spasm, and this part means total recovery. This is the control. And occluded. This is before, this is after. After. And very good flow in the territory of the pica. Other dissecting spontaneous aneurysm. This is the particular situation is an aneurysm. I put one neuroform stent, same of Atlas, similar, is autoexpandable stent and some coiling. But 1 month later, I reopen. This is, no, it's not stable. This is proximal part of the stent. This is distal part. And 1 month later, this is before a new sac. I decide to use a balloon cardiac stent, if you want, to deploy in this part, in lateral view. And you have this effect, real effect. You have the balloon expandable stent here, auto-expandable here, lateral view. Before the second stent, after the second stent. And this is the control. Another case is presented the past 3 weeks, the Vertebro-Basilar basilar aneurysm with mass effect in the thalamo mesencephalo with gliosis, partial thrombus. The patient have a thalamic dementia and progressive dementia, trouble in the speak and memory. This is the aneurysm in AP view, lateral view, don't have the posterior communicant artery functional. In the end of the aneurysm, you are the superior cerebral artery and the posterior cerebral artery. This is magnification. You are the superior cerebral artery, and this is posterior cerebral artery. I decide to put the catheter in the posterior cerebral artery to deploy 1, 2 or more stents. Is not used in this period the flow diverter because the size of the distal artery is too small and the proximal basilar artery is normal, 3.5 millimeters. This is the road mapping. First, Leo stent. Second, two more Leo stent, total 4 Leo stent, and 2 more stent to have a good compact packing in the aneurysm. This is the initial aneurysm. This is the control. Initial, 3 months later, 6 months later, total reconstruction of the vessel. But this is the final control, 1 week later, but 1 year later, regrow the aneurysm. And what happened? You are a endolink is appeared 1 year later. The endolink is in this point, also in this part. I decide bypass. Don't have the professor Shimbu or Hannes near me. More flow diverter, the problem is the thrombus, overlapping stent, or proximal occlusion, or holidays. I decide the overlapping stent. When I overlap more stent, after deploy, the patient have a thrombus in the distal part. I decide to angioplasty in this part. And during angioplasty, the vessel is ruptured. At this moment, I decide to sacrifice the posterior cerebral artery and closing the vessel because the patient bleeding. 1 week later, the patient dead. Now, this is infection in the posterior cerebral territory. This is a complication. Other patient, dissecting aneurysm. This is the point of dissection to distant. AP view and lateral view. I treated also with the stent and coils, but some months later, reopening the aneurysm because the stent going in the sac. I decide to the same to put the endocardiac stent. Is the case. Axial reconstruction, lateral reconstruction. Lateral and axial. This is the angio control with the reconstruction, endoluminal reconstruction of the basilar dissecting aneurysm. This is to look to see the flow. What happened with the flow? This is the flow inside the aneurysm after the stent, the second, the cardiac stent. The flow disappear. Okay, this is some example of dissecting aneurysm in vertebro-basilar territory. Thank you very much for your attention.
Okay, Luis, thank you. Let me see here. I got you off the screen there. Okay. Let me just get you off the screen there, Luis. Okay.
Yes, just a minute.
Yeah, I got it. There we go. Okay, very good. Very good. Okay, any comments or questions from the panelists, please? Okay, a quiet panel. Luis, are you going to have your conference this year?
Luis?
I'm sorry. Go ahead. Go ahead, Ben.
Yeah.
Go ahead.
Yeah. So you treat a lot of this posterior circulation aneurysm, dissecting aneurysms. So how about the occlusion rate for the perforators? The long-term follow-up.
Yes, this is a good comment. The perforator,
Mm-hmm.
the perforator, when you place a flow diverter, sometimes you're at risk to occlude it, some perforate, but it's very low this risk. But in dissecting, In dissecting, aneurysm is different because the dissection progress, and you need to change the flow inside the basilar artery because is the dissection is the origin of the thrombosis of the perforated branch.
Yes, I agree with you. For this kind of lesions, the fluid diverter, normally it's
or a standard stent, whatever you want. Yes.
Yeah.
Yes. Thank you.
Okay, thank you, Ben. More comments or questions from the panelists? Okay, Louis, thank you for being patient with the technology and for giving the presentation. And thanks everyone else. Thanks again, Ben and Yuha, if you're still here. And we'll see you all next week.